Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for January 21st, 2026. Thank you for joining us today. And thank you to the current Osteoarthritis Action Alliance sponsors shown here who help to support our work, which includes the Lunch and Learn webinar series. Now, it is my pleasure to introduce today's speaker, Dr. Jesse Charlton. Dr. Charlton is a postdoctoral fellow in the schools of Kinesiology and Biomedical Engineering at the University of British Columbia, Vancouver, Canada. His work focuses on advancing real-world biomechanics research to support musculoskeletal rehabilitation and healthy aging. He leads a multidisciplinary research program that combines wearable sensing, human interfacing devices, and biomechanics to assess and enhance human movement in everyday environments. By translating lab-based biomechanics into practical, scalable tools, Dr. Charlton is lowering barriers to clinical and real-world movement analysis, enabling more ecologically valid measurements and personalized musculoskeletal rehabilitation. He earned his Master of Science and PhD in Clinical Biomechanics at UBC, where he led innovative research on technology-enabled rehabilitation for osteoarthritis. The title of his talk today is What Do They Do at Home? Technology-Enabled Rehab for Knee Osteoarthritis. Welcome, Dr. Charlton.
Awesome. Thank you so much, Kristen, and to the OA Action Alliance for inviting me to give this lunch and learn. I'm excited to share with you a lot of the work that we've done over the last handful of years, really trying to move biomechanics out into the real world and see what people do when they go home. That's wonderful. So some of the key objectives today, this is kind of I'm going to share some research, but perhaps there's some guidelines or some suggestions that I'm going to embed within this in case you're interested in trying to measure things at home or outside of the lab. So first, I'm just going to talk about a little bit why we should be measuring things at home, how well we're able to actually do that, and then what information we can kind of glean from this very messy, complex data. And then I'll finish with a little bit of the kind of disclaimers, limitations, pitfalls, and things of that nature if you are interested in this. As you heard from kind of the description of my work, I'm a biomechanist at heart. And so a lot of this is going to be leaning towards biomechanics and wearable sensing from the perspective of collecting data at home. First and foremost, I just want to describe a disclosure that I do have. I work with a company called Prova Innovations Limited. They're based out of Hamilton, Ontario, and associated with McMaster University there. We're designing wearable sensing systems that go in shoes and kind of client-patient interfacing software platforms that then allow and augment clinical care for people with neurological and musculoskeletal conditions. So some of this work that I do and some of this information has kind of helped drive some of this innovation forward. So why am I the one talking to you about this work? Well, I kind of have this like 4 bins of work that I do. This includes musculoskeletal biomechanics, largely focusing on knee osteoarthritis. I've got a deep interest in locomotion and the motor control of locomotion, and using wearable sensing to try and push biomechanics out into the real world, all with this idea of trying to find better ways that we can help clinicians and patients move better, live better, and continue to have high function late into life within kind of a real world context. So this is OA Action Alliance. I'm going to not belabor the points terribly hard here, but we know that osteoarthritis is kind of this multifactorial disease. If we take Andriaki's work from some time ago, we see kind of these 3 categories that might contribute to the onset and progression of osteoarthritis, and biological, mechanical, and structural factors live within these normal ranges, whatever those normal ranges are. And what happens is when some of these factors tend to push beyond these ranges, we tend to see the kind of cofactoring with high activity or risk factors that develop into pre-OA and eventually with enough time into full-blown osteoarthritis, and that cycle kind of continues. Of course, the structural piece is not the only part. In fact, it's a smaller piece considering the pain and functional deficits that people do experience when they have OA. People with OA tend to have higher healthcare costs and usages, lower physical activity, and these can ultimately lead to loss of mobility and independence later in life. So this is obviously a major problem. We all know this. My work is largely focused on the mechanics of this question. Some of you may be familiar with this, but when we think about mechanics, we think about some of the previous research, largely in animal models, where we're understanding that loading on the cartilage can be detrimental over time. Now, of course, cartilage lives within a living body. And when we try and do these types of experiments in humans, it can be quite difficult. So we have to use the tools of biomechanics to try and estimate the loading on the cartilage and how that might be affecting structure and pain and things of that nature. We use motion capture like this. We have markers placed on the person. We have them walk over force plates. We combine that information and we can get things like net torques about the joint. In knee osteoarthritis in particular, you'll be well aware that the frontal plane moment about the knee, or the knee adduction moment, as you may have heard it called, is kind of one of the key outcome factors. And the idea here is that that knee adduction moment has a tendency to rotate the tibia with respect to the femur, creating compression on that cartilage, more load, and ultimately further degeneration. When we measure the knee adduction moment during gait, we tend to see this kind of bimodal, double humped pattern, if you will, with a peak early in stance and a peak later in stance. And the details of this aren't terribly important. The point is that when we look at kind of all the data together, we tend to see that higher knee adduction moment magnitudes, be it peaks or impulses, tend to confer greater odds of progression over time and worse pain during walking. So you might say, okay, what do we do about this? Well, we obviously want to potentially change the knee adduction moment. I'll note here too, you'll see these QR codes pop up throughout the talk. These are papers that are associated with the slide or some of the work that we've done. So feel free to catch those and go have a look at the research itself. So we want to change the knee adduction moment. There's a number of different ways we can do this. There's surgical interventions, there's bracing, there's orthotics, and there's also movement modification. And my work has largely looked at subtle changes to the foot progression angle. This is how much your foot is toed in, or think pigeon-toed walking, or toed out, think duck-footed walking. So what does this actually do? Well, if we take somebody as a baseline walking neutral, feet straight ahead, perhaps we see something like this for the knee adduction moment. It's kind of a fairly even bimodal curve. We then have somebody turn their foot outward. We reduce the knee adduction moment by bringing the ground reaction force closer to the knee, and we tend to see this reduction as you see here in blue. Conversely, if we turn the foot inward, we see kind of a slightly different approach, but generally speaking, a reduction in the knee adduction moment as well. And the selection of these can be biomechanically driven or comfort driven. Some people prefer performing a toe in versus a toe out and vice versa. But ultimately, we tend to see a bit of a dose response effect. So if you change the foot progression angle, you tend to get concomitant changes in the cam. The larger you change it, the larger you get reductions in cam. This is to a point. You can imagine if you walk too far out, we're thinking usually beyond about 30, 35 degrees, things get a little bit funky, and that's probably the upper limit of where you'd want to be targeting. So does this actually work? Well, we conducted the first controlled trial. There's now been a recent one published by Scott Ulrich and his colleagues, which is an excellent read in the Lancet Rheumatology, if you want to look at that. But our controlled trial, we had 80 adults with knee osteoarthritis. This was symptomatic and radiographic knee osteoarthritis. They entered into a 4-month training program. They were split randomly into 2 groups. One group got a walking program. They just generally were trying to increase the amount of walking activity that they did. The other group got a walking program, same as the other group, plus an intervention to increase their toe at angle around 15 degrees. They did this through weekly or biweekly meetings with a kinesiologist at the university, training with some biofeedback, learning to increase that toe out pattern, and then practicing at home over the 4-month training program. So by the end of that program, we had 9 degrees of change in the foot progression angle. This conferred about a 10% reduction in that knee adduction moment peak magnitude and impulse. And we got a reduction in pain. It was about 57% within group. The treatment group, or T that you see at the bottom there, had a delta of about 2.7 points on the 0 to 11 or 0 to 10 point NRS. The control group had about a 1.4% reduction. So this is all to say, Seems pretty reasonable, seems fairly easy to implement. People were able to integrate it into their life, and we saw the biomechanical and symptomatic improvements that we cared for. But we had no idea what people did when they got home. And so in between these practice sessions, we didn't know if they were using this intervention, if they were using it a little bit, a lot of it. We really didn't know. And this is kind of where a lot of the work that followed came from. So we wanted to know what people did at home. And as you can imagine, my interest was really focusing on the foot progression angle piece. How much are people changing their feet? How does their walking about in the real world affect that measurement? And are we able to actually track what people are doing over an intervention and in their real life? So we developed what I call a lab in a shoe. This is an inertial sensor that we embedded in the shoe, and we were able to track the foot progression angle. With some clever algorithms that then take some of the signals from this IMU, we then fuse them to get the orientation of the foot, and by estimating the direction of walking, we can get the foot progression angle. We're able to do this with about 3 degrees or less of error and an SEM of about 1.3, so this is pretty satisfactory for what we were looking for. So first, we sent the shoe home with people, and we collected data for a week. We just said, we want you to walk with this. As much as you're able to, please walk with the sensor. The data that you see on the left is from one participant accumulating good steps of walking that we were able to collect over that week. The red line is the in-lab measurements, and they're nice, controlled, straight-ahead walking, the usual biomechanics drill. And the blue is the accumulation of that foot progression angle over time. And you can see they converge quite nicely. This is to say that there seems to be some consistency or some congruence about what we measure in lab versus what we measure in the real world. And indeed, that's what we see. Here we have data from healthy adults in red, knee osteoarthritis adults in blue. The lab data is the solid color, the real world is the open color, or white. And the median foot progression angle, basically bang on. People are quite consistent in how they behave between lab walking and real world walking. So this is great. But as you might expect, when people walk in the real world, we see a lot more variability. And this was quite substantial. Here measured with the coefficient of variation, we see substantial increases in that real world foot progression angle variability compared to the lab. Now, despite that variability, people walk quite consistently in the real world. So here we're taking real world bouts. These are 7 bouts in a row of all of the participants in the data set. We then median centered all of their foot progression angle data to see how they fluctuated around the median value for themselves. And when we look at the distributions, we really see that they're fluctuating about plus or minus 2 degrees. So this is to suggest that people are quite consistent across how they walk. It's just they walk quite variable in the real world compared to the lab. So this tells us that we can capture kind of measures of central tendency in the lab that are quite reflective of real world data, but we're missing that variability piece. The next question that we had was, how much data do we actually need to collect? When we bring people into the lab, the kind of typical biomechanics idea, especially if it's overground, is you collect 5 good strides of data with a force plate strike, and you take those and you average them, and boom, there's your value for that person. I would argue that's insufficient, but that's generally the accepted practice. How much do we actually need to collect in the real world when we've sent the sensor home with someone and we have no idea what they're doing? And so we took this week of data, and we did this kind of bootstrapping approach. This was an iterative bootstrapping strategy where we took a set of their walking data and incrementally increased the number of steps in that set, and then added new steps to that data set to see if it would change the distribution and the parameters of that distribution. The idea here is to say, how many steps do we need to actually have collected before adding more data really doesn't change our measurements for that person. We call this the stability point, or how similar the distributions were. And we based this stability point on kind of where on these power curves we saw a change that was less than 0.0% that extended out 500 strides ahead of the query point. And so when we look at 2 metrics here, foot strike angle, this is the angle of the foot with respect to the ground at heel strike on the left, and foot progression angle, we see fairly similar results. Foot strike angle needed about 650 of these steps, and foot progression angle needed about 980. Now you might wonder, well, what does that mean? Well, if you're thinking about around 1,000 steps to cover these off, that's really about only 20 minutes of walking. So if you send somebody home with these sensors for a few days or maybe even a week, you're going to get 20 minutes of walking. And that's to say we should be able to produce representative data from these data collections. The next question we had was, what happens if people are walking on different terrain? Undoubtedly, if we send some people home with these sensors and they're walking in their community, in their home, at work, they're going to be walking on slopes and stairs and flat ground and all sorts of mixes. So we wanted to see what happens when people do this. We took 10 healthy adults. We had them walk on up and down slopes, flat grounds, stairs, up and down as well. And we did some sensor analytics to try and get to what happens to the foot as people are moving through these spaces. The first step was to get gait events. I'm going to breeze over this a little bit, but if you're interested in the details, I'm happy to talk more. We got gait events, heel strikes, and toe offs. Importantly, we figured out when the foot was flat on the ground and not moving, or the zero velocity update point. Then we did orientation estimation. So we fused some of these signals again from the angular velocity and the acceleration. This tells us the orientation or position of the foot in space. We then removed gravity using that orientation. And so all we had was the acceleration of the foot without gravity corrupting it. And then we were able to do a double integration. For those of you who are familiar with the issues of integration, if we did this double integration without any other consideration, we'd get quite a lot of drift. And so that's where that zero velocity update comes in. We integrate once from one foot flat or a zero velocity point to the next. We then can correct it because we know that the zero or the velocity should be zero, and then we integrate again. We get these nice foot trajectory patterns that you see here in gray with the average in red. Now, the foot trajectory patterns here, just a representative participant, but what we can see is that when people are walking uphill, they tended to extend their strides a little bit. When people are walking downhill, they shrunk their strides a little bit, perhaps having to do with obtaining enough friction in that foot when they were contacting the ground so they didn't slip. And then when walking on stairs, we see quite a substantial retraction of that stride length, largely due to the geometry of the step. But what does this do to the foot orientation measures that we talked about before? Well, with foot strike angle, we see here when walking on slopes and flat ground, there's a positive value. This is largely, or this is suggestive of a heel first contact, as you might expect when people are walking. But when you then go to the stairs, we see an inversion of that. People are tending to land flat-footed or toe first. Those are depicted by the negative values. For foot progression angle, we see reasonably similar accounts, at least based on the median across these different conditions. There's some variability between people, no doubt. But broadly speaking, foot progression angle didn't seem to change a whole lot for a given person across these different terrain conditions. So this tells us that terrain is important. It's something that you probably need to consider if you're doing these real-world data collections, but it might not be as important for all variables like the foot progression angle. Okay, so we did all of this. We tried to understand what we were able to actually measure in the real world, how we need to be able to do it. Then we wanted to put it to the test. So we wanted to see if we could send people home with an intervention for gait modification, wearing the shoe, and then what do they actually do in between the baseline and the follow-up. So here we did a 6-week delayed control clinical trial. We had 20 adults with knee osteoarthritis. You can see the demographics there on the far right. We brought people in for a biomechanics screen at the very start. We wanted to see whether a toe-in or a toe-out pattern was best for them. And whichever one was best for them, that's what they were prescribed for their modification. They then took the lab and a shoe home. They wore it for a week. That gave us our baseline natural walking behavior in the real world. They came back for baseline, and they were either told, we want you to toe in as much as is comfortable, or we want you to toe out as much as is comfortable. See you later. And they went home for 6 weeks wearing the shoe. Every week we had a video conferencing call as kind of a checkup, seeing how things were going, talking about any issues that they're running into, and then we brought them back for follow-up and ultimately retention. Just going to talk about some of the data here. First, looking at the foot progression angle. Here are data binned into 2-week bins, and then looking at the follow-up and retention periods as well. These are distributions across all participants. Going further on the right, on the x-axis, means larger absolute changes in that foot progression angle. And what we can see is that over the duration of that intervention, we see a shift away from that baseline. By follow-up, we are getting around 11.4 degrees of change. If you think back to that previous RCT that we did, we had weekly training sessions with biofeedback. It was 16 weeks long, and we got about 9 degrees of change. So that's to say that there's possibility that we're able to actually tell people to just do the thing without providing a ton of biofeedback to them. And we're able to see it in the data, but also see it in the real world, which I think is pretty interesting. Now, if we want to change foot progression angle, that's great, but really what we care about is changing the biomechanics. And what we see here, again, is a reduction of about 12% in the knee adduction moment magnitudes at follow-up, which was great. So we're able to get that biomechanical change that we are looking for. Now, biomechanics matter, but really what matters to the patient is their pain and their function. So we also measured that, and we saw modest changes in pain based on the NRS pain scale, as well as the KOOS pain scale, and improvements in function as well within group. But again, this is about what people do at home. And so those measurements that I showed before were at baseline and follow-up comparisons. This is in the lab when someone's staring at them and asking them to complete a questionnaire. But we also gave them a diary throughout the intervention and asked them to measure or report their pain, both pain during walking on a 0 to 10 scale and pain overall on average during the day. Now you can squint and tilt your head and maybe try and see that there's a bit of a shift to the left in some of these distributions, but I don't know. I'm not terribly confident in saying that there's massive changes across these weeks with respect to week 0 being that baseline walking week. And that's just to say that perhaps what we're measuring in the lab when we have this kind of white coat effect and people are looking at you and asking you to complete these questionnaires doesn't necessarily represent the experience that people have when they're going through these interventions. And so this calls for better measurements of pain, but also considering how these interventions are enacting in the real world and creating potential change for participants. Now, going back to that disclosure I mentioned before, a lot of this work is really trying to move biomechanics out into the real world and helping patients and clinicians work together to manage their rehabilitation. This is partly what Probe is trying to do, both in our device and in the platform. So if you are interested in this, we're trying to see this progression as kind of a lab in a shoe to something more like a clinic in a shoe. So certainly reach out if you're interested in these sorts of technologies. Now, I'm going to finish off here just talking about some of the precautions or limitations. When you're doing real-world data collection, by and large, you're doing this blind. Do you know what you're actually measuring? And most of the time, you know what you think you're measuring, but you don't necessarily know the context that they're happening in. And so this can create a lot of extra noise in the data that you actually end up acquiring. There's also a lot of technology limitations. Sensors can be really finicky. They can be easily broken. I can't tell you how many sensors were crushed under people's feet or chucked into a washing machine over our interventions and studies that we've done. And so it's really important that you consider these limitations and the kind of form factor that you ultimately end up using. The other piece is that nowadays with these commercialized and reasonably cheap wearable sensing systems, it's really easy to do this data collection, and it's really easy to collect useless data. And I say that as a precaution. I really recommend that you connect with people who know wearable sensors well and the technologies and the limitations, and try and look at this from a team science perspective, and you're going to get a lot more success in the end. So when should you be doing this? When should you be aiming to collect data at home and outside of the lab? And kind of the obvious thing is you're curious of what people are doing when they leave the lab. That's great. That's level 1. But what's critical is you need to know how much data you actually need to collect and if it's feasible within the confines of your study. You need to know what measurement you're trying to do or take, whether you can do it directly or if there's an accepted proxy that you're comfortable with. And then you need to understand the dynamics of those measurements over time and what that might mean for the stability of your measurement or how you might be able to draw conclusions. Slightly less critical, but still important pieces are, is your measurement device user-friendly? Is it a set it and forget it? You stick it on the participant and you get it back a week later and everything's happy? Or do they have to fiddle with it? Do they have to charge it? Do they have to turn it on? These are important considerations. And then you also need to have algorithms and data analytics to be able to process a lot of this blind collection and actually pull out context and relevance within them. This is just to say again, this kind of the summary of what you need to be thinking about. But the key is to work with people who are doing biomechanics and wearable sensing day to day, as they can really add a lot of value to your study and ensure that what you're measuring makes sense and is reliable and real. So with that, I'll thank you all for listening. If you have any questions, you want to talk more about this stuff, you want to work together, please email me. You're also welcome to connect with me on LinkedIn, which you can get at the QR code there. I'll be starting my lab very soon at the University of British Columbia, the Applied Musculoskeletal Biomechanics Lab. If you're a student, you're interested in coming to UBC, working with me, please again reach out. I'd love to hear about your ideas. Awesome. Thanks, Kristen.
Thank you so much, Dr. Charlton. That was a wonderful presentation, really interesting work. We have time for Q&A, so I will give people a chance to think about a question, type it into the chat box, and we will discuss it out loud. So I actually do have a question. You had mentioned that pilot clinical trial. Could you expand on that a little bit? It sounds like there were some interesting features of the study.
Yeah. So there's been a handful of clinical trials in the past that have been kind of fairly straightforward. You bring people in for a treatment, you give them biofeedback, you send them home, they practice, come back and follow up, and you measure things. And really, what we wanted to try and advance in this clinical trial is both how we're prescribing the intervention. I mentioned that briefly with our screen, but then also trying to advance how we're delivering the intervention itself. So as I said, in the past, people use real-time biofeedback, and that's great. We know people can learn from real-time biofeedback. But what I wanted to see is people are smart. They know what they need to be doing, especially with things like subtle changes in your movement. And so we wanted to test this idea of just simply giving them an instruction. So I just want to kind of harp on the fact that what we did with that clinical trial is we got similar results biomechanically and symptomatically from a shorter intervention where all we did was at the baseline assessment say, we want you to toe in or toe out as much as is comfortable for you. Go. There was no real-time biofeedback. There was no clinic appointments other than kind of virtual calls over video. So that really kind of opened our eyes up to the fact that perhaps we don't need to have such involved interventions, and therein allowing us to potentially do some work more abroad or through kind of a telehealth model that might still be able to get the responses and results that we're hoping for.
Thank you for clarifying all of that. And I also noticed from the limitations that you posted and a couple of things you said throughout the talk that, you start to lose a little bit of control with going outside the lab and that the devices can be finicky and so forth. What challenges did you encounter when you start looking at the patient's at-home sensor data or their pain data?
Yeah, so the sensor data for sure is a big challenge. Again, if you're able to stick on a sensor and leave it on them, they don't take it off, they shower with it and everything in between, you can get away with quite a bit because you're really able to kind of decide how it's being placed. It can be placed by an expert and collect the data that you anticipate. We didn't have that, although we did have it embedded in the shoe. So there was kind of a confine in which the sensor had to sit. And so we knew how that sensor was positioned with respect to the shoe mostly. Some issues occurred where people put it in upside down or backwards. And so you need to have checks and balances in your algorithms to assess, okay, we think this is walking ongoing, but the signals are flipped maybe. And so you kind of need to be able to double check that and then correct things accordingly before you start binning or running your algorithms that potentially have assumptions based on the orientation of that sensor. There's some new algorithms now that are great that kind of remove some of that requirement, but it's still nice to know exactly how that sensor is being placed. And when people are allowed to place it, however, you tend to get a bit of a mess. So you have to be careful there. The other piece is you're measuring things in these kind of blind contexts, and contexts matter. There's some really nice work by Lavna Barudi, and she's looked at kind of how context change the dynamics of people walking, particularly in the kind of spatiotemporal space. And so you want to be considerate of the fact that people are walking perhaps with their dog, with a friend, to the store, they're rushing for the bus, or in the grocery store. And these might change the behavior that you're actually seeing and measuring, and creating additional variability in your data set. And so you might want to be able to pull out those contexts if they really matter. If they don't create bad variability, so to speak, in your data, and you're okay with it, then maybe you can get away with a little bit less processing.
Thank you for that. And I will note we do have two questions in the chat that I would like to get to in just a moment. But I'm noting that we are at the end of our stated 30-minute time frame. So for all of you who need to hop off, I would like to just again thank Dr. Charlton and all of you for attending today. I will launch a brief satisfaction poll for today's presentation if you can quickly answer that before you hop off. And then one other final note that our next presentation will be in March. We are moving to a bi-monthly or every other month schedule for 2026. So March 18th, please join us for the presentation, Why Employers Matter, Expanding Coverage for Evidence-Based Chronic Disease Prevention and Management. I just put that information in the chat. So if you have a minute to stay on, by all means, we'll get these last two questions addressed. And otherwise, thank you and have a wonderful day. So one of the questions, you've already addressed a little bit of this, I think, in the limitations about the sensors breaking when you send people home or they go into the washing machine or what have you. But can you tell us a little more or anything different about the patient's perspective and opinions about wearing the sensor at home and what the level of burden or acceptability that was?
Yeah, this is great. This is from Haral, who I know well. It's good to hear from you. Um, yeah, so I was meaning to include a little bit of qualitative data that we collected from that pilot trial, but just for time's sake, I wasn't able to map it into the talk. For us, at least, with these particular sensors in this particular context, we had modestly positive mixed reviews, I would say. Some people found they were easy to work with, they were easy to fit into the shoe. They didn't mind having to remember to turn it on before they went for a walk and then those sorts of things. So it was reasonably positive. Some people didn't like them at all. They found that having that sensor underfoot was a bit uncomfortable, or they would sometimes forget. And this answer is really just to highlight that we can talk about how wearables may or may not be a good thing for people at home, but it's really context dependent, it's population dependent, it's application dependent. I think it's quite variable. All in all, though, the goal is to really try and create the most frictionless systems that anybody can use and collect the data that matters most, that allows us to action decisions. And I still think we're a ways off from that quite yet.
All understandable from the participant perspective. One final question: with the recommendation to toe in or toe out as much as comfortable, do you also provide recommendations for calf stretch of soles and gastrocnemius to allow people to have a better heel strike and have better uh, toe in walking?
Yeah, so I almost inevitably every time I talk about gait modification and foot progression angle changes, I get some questions about basically like how can we accommodate people as they learn to do this, and what sort of adverse events do we typically get. So generally speaking, when we've applied this in the past, we haven't strictly told people as part of the protocol to perform some strengthening or some stretches in the gastroc or soleus. And this is largely based on the fact that our experience so far is that when people try and integrate this and they do so with some intention over time, the first week or two, it'll be a little bit uncomfortable. Maybe they have a little bit of niggly pain in their ankle. Maybe their lateral hip muscles are a little bit sore, overworked. But that fades usually quite quickly after a week or two of trying to integrate this into their walking. And so we really frame it as, like trying a new exercise in the gym. It's good for you. It's going to be a little bit sore for a bit, but eventually you'll kind of accommodate to it. But if we have people who come back and say, oh, my ankle has been quite stiff or my hip has been quite stiff, that's when we start to think about these kind of concomitant physical therapy-based recommendations, like some stretching or some strengthening. But broadly speaking, we haven't needed to use that all that much. People are quite adaptable in this sense.
Wonderful. Thank you so much, Dr. Charleston. I think we will leave it here. Certainly, I know that you provided your contact information if anyone has any additional questions. Otherwise, everyone, enjoy the rest of your day, and we'll look forward to seeing you in March.
Thank you, everyone.